Hello, my name is Erin Hurst, and this is my 5-minute video on hip dysplasia. Hip dysplasia is also known as developmental dysplasia of the hip. With this condition, a shallow acetabulum does not fully cover the femoral head, allowing hips to become partially or completely dislocated. It can be congenital or acquired. However, it's most often present at birth, but can occur anytime during the newborn or infancy period, usually due to inappropriate positioning. 9 out of 10 cases are caught during infancy. The severity of hip dysplasia depends on when the condition was found and how it was treated. Mild, untreated hip dysplasia may not affect children until they are teenagers or young adults. Silent hip dysplasia that's found in adults is the leading cause of hip osteoarthritis in adults under the age of 50 and accounts to 5 to 10% of all hip replacement surgeries in adults. There are many risk factors associated with hip dysplasia. Genetics plays a big role. Breech positioning in the womb can limit movement and places hips in a position of flexion and adduction. Females are 4 to 5 times more likely to have hip dysplasia. Positioning after birth with the use of a cradle board or inappropriate swaddling or using baby carriers that do not allow for proper hip alignment. Low amniotic fluid or first pregnancies can limit fetal movements, and then concurrent foot deformities or torticollis can also increase your risk of hip dysplasia. Most cases of hip dysplasia are discovered during the physical exam and a well-child visit. Some questions that you may ask would be, is it difficult to change your child's diaper? Because immobility or reduced abduction in one or both legs during diaper changes can be a sign of dysplasia. Or if the child walks with a limp, because if they do have hip dysplasia, they could have a positive Trendelenburg, which is a waddling gait. In adults, you're going to ask if they're having new hip or groin pain. Pain's often the first sign in adolescents and adults, and the pain will be described as deep in the front of the groin. It will increase with walking, standing, or running, may occur at rest, and may be associated with the sensation of catching, popping, snapping, or locking that is usually painful. You're also going to want to ask if they're walking with a new limp, which is very common in the early stages, and this can be a painless limp or a limp associated with pain. So a hip development screening is a part of the normal well-child screening from birth until about 9 months. So the two maneuvers that you're going to use to assess for hip dysplasia during this time period are the Barlow and Ortolani maneuvers. For the Barlow, if it's positive, the hip can be dislocated from the acetabulum with the motion, and the dislocation will be palpable. And then with the Ortolani, the femoral head is reduced back into the acetabulum with the motion and will produce an audible click. These maneuvers are not as effective after about 3 months of age, so we still do them, but you need to look for other physical findings as well. And some of these would include limited abduction on the affected side. You might have an asymmetrical gluteal or thigh fold, which it's shown here. You could have a positive Trendelenburg gait. You could have a positive Galeazzi sign, which one limb appears shorter when the patient's in this position. And then children with bilateral hip dislocation would have a significant sway back when they're walking. With adults, you're going to look for a new pain or a new onset of a limp. You're going to assess for pelvic tilt, leg length discrepancy, or muscle wasting. You might note muscle tightness during hip abduction, and the impingement test will cause a pinching sensation in almost all patients with hip dysplasia. The primary goal of treatment in pediatrics is to hold the hip in the socket until ligaments go back to normal and allow time for the socket and bone to grow to the proper shape. Treatment is individualized based on the severity of dysplasia and the age of the child, and early treatment is key to minimizing lifelong complications. So for newborn to 6 months, you're going to use a Pavlik harness or a similar device. They'll usually be worn for about 10 to 18 weeks. From 6 to 18 months, you could do a closed reduction. The hip is then relocated without surgery, and the child is placed in a spica cast for several months. However, if the dysplasia is severe, you may progress straight to surgery without attempting the closed reduction first. 18 months to 6 years old, you'll use an anterior open reduction of the joint with additional bone surgery and ligament tightening as needed. The surgery puts the hip back into the joint, repairs the ligaments, and realigns the bones, and then a body cast is usually worn for 6 to 8 weeks. After 6 years old, there's no treatment for a complete dislocation because the bone changes are permanent, so you will just typically use supportive treatment until they get a little bit older. In adults, for mild dysplasia or mild symptoms, you're going to choose non-surgical options as your first-line treatment, which would include lifestyle modifications like weight loss or low-impact physical activities, physical therapy, or joint injections. Hip-preserving surgery would be your next line, and this surgery is done to change the orientation of the hip socket so it has a better positioning to cover the femoral head, which improves the longevity of the hip joint, and this can be done in children as young as 11 years old. And then your final option would be a joint replacement. You need to teach proper body positioning for newborn and infants. This includes how to properly swaddle an infant and how to choose a baby carrier that's hip safe. It's what this picture is right here. The legs should go around the body. Parents should not use cradle baby slings like this. You want to let parents know that most children will not need to use any assistive devices when they're older, and kids in braces and casts can still move and play to their ability. And then you're also going to want to reassure parents that there are no known ways to prevent hip dysplasia, and it is imperative to stress this to new parents, especially mothers who may blame themselves for this condition. Thank you.